Welcome to this essential guide on understanding and managing cervical polyps. As a woman or a healthcare professional, it's crucial to be informed about cervical polyps. Today we will explore the definition, etiology and pathophysiology, risk factors, clinical features, differential diagnosis, investigations, and management of cervical polyps. Cervical polyps are benign growths protruding from the inner surface of the cervix. They are typically asymptomatic, but a very small minority can undergo malignant change. They are estimated to be present in 2 to 5% of women. In this article, we shall look at the clinical features, investigations, and management of cervical polyps. Cervical polyps develop as a result of focal hyperplasia of the columnar epithelium of the endocervix. The etiology is unclear, but suggested causes are chronic inflammation, abnormal response to estrogen, and localized congestion of the cervical vasculature. They are more common in multigravidae, with a peak in incidence between 50 and 60 years of age. Cervical polyps are often asymptomatic, identified only via routine cervical screening. If symptomatic, the most common clinical feature is that of abnormal vaginal bleeding. This can be in the form of menorrhagia, or intermenstrual, postcoital, or postmenopausal bleeding. Polyps can also cause increased vaginal discharge. Rarely, they grow large enough to block the cervical canal, causing infertility. On speculum examination, cervical polyps are usually visible as polypoid growths projecting through the external os. There are a large number of possible causes for abnormal vaginal bleeding. These include cervical ectropion, or cancer, sexually transmitted infections, fibroids, endometritis, and pregnancy-related bleeding. In the postmenopausal population, always exclude endometrial carcinoma. If a polypoid lesion has been visualized within the cervix, the alternative diagnosis is an endometrial polyp. The definitive diagnosis for a cervical polyp is histological examination after its removal. The main role of any other investigations are to exclude alternative causes of the symptoms. Triple swabs. If there is any suggestion of infection, endocervical and high vaginal swabs should be taken. Cervical smear, to rule out cervical intraepithelial neoplasia, CIN. Sometimes the polyp can prevent the smear being taken, in which case the smear should be repeated after the polyp has been removed. In approximately 27% of women with cervical polyps, there are also associated endometrial polyps. This is particularly the case in the postmenopausal age group. If symptoms of bleeding persist after removal of the polyp, an ultrasound scan should be arranged to assess the endometrial cavity. Cervical polyps have a small risk of malignant transformation, so it is common practice to remove them whenever they are identified. Small polyps can be removed in the primary care setting. The polyp is grasped with polypectomy forceps and twisted several times. The polyp is avulsed as the pedicle becomes twisted. The polyp should not be pulled off as it will result in more bleeding. Any resulting bleeding can be cauterized with silver nitrite. Larger polyps, or those that are more difficult to access, can be removed by diathermy loop excision in the colposcopy. Any excised polyps should be sent for histological examination to exclude malignancy. They have a recurrence rate of 6–12%. Complications of a polypectomy are rare, but include infection, hemorrhage, and uterine perforation. To reduce this risk, only polyps that are visible easily should be removed in the outpatient setting. You should not blindly attempt to remove polyps from within the cervical canal or that are intrauterine in this setting. Thank you for joining us in this educational journey on understanding cervical polyps. Stay informed and take proactive steps to safeguard your health.